major chunk as it is a radiology course. So today's talk will be primarily by Dr. Navya, but as practicing pediatricians and fellow neurologists, it's very important that we know the clinical signs and the scenario where we probably suspect a pediatric tumor or a setup wherein you should be very highly suspicious of an entity that has very devastating outcomes if not treated on time. So the first presentation, see, pediatric tumors can present in all three ways: acute, subacute, and chronic. So please remember that we only talk about acute presentations, but it can happen in subacute and chronic. So acute presentations, the first one would be ataxia and focal signs. So this is the commonest situation. We have a child who was previously normal and coming to you with acute onset, focal signs like cranial palsies, multiple cranial palsies, and also ataxia or some hemiparesis that strongly indicating that we are probably dealing with some posterior fossa tumor. So that is a commonest scenario we see in acute onset tumors with aggressive grade. The second one, these symptoms can last in the same way for subacute onset, like going on and off for a couple of weeks, ataxia on and off, which is increasing slowly. There's on and off headaches, and there's very subtle facial nerve palsy and two or three cranial nerve palsies coming later on. So focal signs and ataxia are progressing very slowly, and a subacute onset presentation is also known in pediatric tumors. With it depends on the grade how fast they're going. So that's the second one, and the third one is going to be a chronic presentation. Chronic presentation. Also think of a pediatric tumor. Unlike if it's a slow growing tumor, the child could have on and off headaches, just headaches. So always remember, never ever misdiagnose a headache just by saying it's a migraine or a refractive error. So whenever we have a child in your OPD or ICU coming with a chronic onset headache or a primary headache like disorder, going on and off since a lot of months. So do ask for red flags, especially ask for early morning vomitings, projectile vomitings, occipital headache, and headache not relieved by taking analgesics, and headache lasting for a long time, and the pain scale of headache more than 8 by 10, with focal deficits, with papilledema. All these are very bad signs or red flag signs. You should be very aware that do not disregard them as migraine or tension headache or any primary headache disorder. They do consider neuroimaging at the right time for better prognosis. And that was the third type of presentation, like acute versus subacute versus chronic. And there's two other forms of presentations. One would be a predominant seizure type of presentation. So this is one specific feature of few tumors which predominantly are known to present with seizures. So this would be your DNET. So DNET is a neuroectodermal tumor. So this is one of the primitive tumors which primarily arise from medial temporal lobe. So they have a predominant seizure kind of presentation. So they have temporal lobe involvement. You have typical. I recently had patient with not major semiology of seizure, just he has motor arrest. So if you know, temporal seizures are known for just behavioral or motor arrest. They won't have any tonic-clonic movements. So whatever they are doing, they just stop doing. It looks like absence, but we don't have the EEG correlate of absence. They just have behavioral arrest or motor arrest, followed by you can have other signs like focal signs. We have autonomic manifestations, sweating, pallor, cyanosis. All that can happen, and sometimes they also have aura. Temporal lobe seizures usually start with aura, like of abdominal pulsating sensations or rolling like sensation, roller coaster like feeling. All that can happen. So do remember, DNET is one of the tumors which can present with full-fledged seizure-like presentation. And the second category in that seizures is hypothalamic hamartoma. Do remember, hypothalamic hamartoma, as the name itself says, it usually arises from hypothalamus or the tuber cinereum. So the presentation of this would be typically with gelastic seizures. Gelastic seizures means basically the semiology of the seizure. The child starts with smile without a particular reason. So it's called smile without mirth. So we'll have multiple episodes of smile and laughter without any reason that can go up to, like, days and days together, and sometimes the entire day they'll be just laughing for no reason. So that is gelastic seizures that can happen in hypothalamic hamartoma or any cortical tumor in tuberous sclerosis sitting in the temporal lobe or a front inferior frontal lobe can present with gelastic seizures. And the final type of presentation would be a paraneoplastic type of presentation, opsoclonus myoclonus ataxia syndrome. If you see, it is a paraneoplastic syndrome of a primary neuroblastoma. So neuroblastoma can be elsewhere, not in the brain, but usually in the abdomen. But they can also present with neurological manifestations like omas. And last but not the least, some people can present only with vision problems like optic nerve gliomas. Optic nerve gliomas can be a part of neurofibromatosis type 1 and some cancer predisposition syndrome. So they'll also present with predominant vision loss. And when you do a neuroimaging, you'll find an optic nerve glioma. So to just summarize, the presentations of pediatric tumors can be diverse. You have acute kind of presentation with ataxia, focal signs, cranial nerve palsies, and hemiparesis. Subacute, these symptoms going very slow. When you see chronic type of headache, a chronic type of presentation, you have headaches which are going for a long time with subtle red flags like occipital quality, early morning headache, early morning vomitings, uh, per headache not fitting in any primary headache disorders, headache with papilledema. And these are subtle signs wherein you should start doing early MRI. CT would not be the appropriate investigation in this setup. And as I said, seizures in DNET, gelastic seizures in hypothalamic hamartoma, in DNET usually have temporal lobe seizures and vision issues in optic nerve gliomas. I think that would be a good prime. Diagnose it early. Clinically, you have to suspect that no, it could be an underlying malignancy. And once the imaging is done, most of the times we have MRI with MR spectro and with the opinion of neurosurgeons and also medical oncologists will come to a diagnosis of what is the probable entity. We'll now discuss the radiological aspects of various tumors. Hi, Dr. Navya. I think you can take over now.
Yes. Yes, hi, I'm Dr. Navya. The topic given to me is basics of radiology. The feat is pediatric neuro-oncology. I'm not a radiologist. I'm not a pediatrician, not a neurologist. I'm just being an oncologist here, as Dr. Jayanth had made a good platform for me. He has talked all what I have not included. Thank you so much for that, because those are all mostly, the non-malignant part of the oncology. I will be dealing with the most of the malignant parts. So I would rephrase it in a better way, pediatric neuro-oncology with basics of radiology. Yeah, there's no conflict of interest. So I believe step one and two has already been done, because it's been a series of radiology program which has been going on as per my understanding. So you've probably understood the imaging modalities and when to use them. You have already mastered probably the basic and advanced MMRA protocols. If not, I'll also try to make you learn a little. And then, the most importantly, interpret the common pediatric brain tumors and recognize the tumor location. What are the patterns? How do you differentiate between both, between two, major types? And finally, at the end, how do I assess the treatment response and how do I keep the child in surveillance? So the multidisciplinary tumor board happens for us at Arya Cancer Institute. The head neck board happens every Thursday, and there's a local joke which would happen where the medical oncologist knows the radiology only to see if there's a tumor or not, if it is a recurrent or not, and if it is post-RT or not. These are the three things only which the medical oncologist is particular about. But on the other side, the radiation oncologist also has to know extra what's the tumor volume, which he needs to target, of course, and also how close is that to the optic chiasma and the brainstem? Of course, the surgical oncologist would need much more detail in depth. What is going to enter into how much is the functional deficit is going to create? How acceptable should that be? It will be in all his pre-surgical counseling, and what is the things which are going to happen after surgery, everything. So he needs a more detailed thing. This is what a group joke head neck MDT. So the epidemiology, as you see, the World Health Organization has started an initiative by 2030. It wants to cure all. The theme is called Cure All. You see it on the left upper side. It want to cure all the possible diseases which we can. And in that, the low-grade glioma is also one of the diseases. So starting with epidemiology, these are the most common pediatric solid malignancies, the brain tumors. The peak incidence is usually around 3 to 8 years of age, with an incidence of 3 to 4 in 1 lakh children per year. Posterior fossa tumors, mostly the MB and medulloblastoma and ependymoma, the most common ones. Coming to the supratentorial, it would be gliomas and germ cell tumors. This is what I was talking about. So all the spectrum of 6 diseases, the first 3 being my favorite, and then also a little on these. So what you are doing, what Dr. Jay and Dr. Nitin sir are doing is they are connecting the vital partners. Okay, they are connecting the health systems. They are giving the insight to all the persons who could be get involved in achieving us this goal by 2020. So MRA is the workhorse, as you all know. So for the soft tissue, it's a superior modality. There is no radiation, and it is preferred for my diagnosis and follow-up. So the T1 weighted image, we are getting into the MRA protocol thing. The T1 weighted image, where I'm knowing the anatomy, margins, enhancement, and if any, the leptomeningeal spread. And if it is a T2 weighted image, I'm more inclined to see on T2 is what I want to see is the edema, what is the CSF interface, what are the cysts and peritumoral changes. And flare, it's just a flip side of T2. And in contrast, what I need to know, so there is a uniform blood-brain barrier which is there, and if that's broken down by a very harsh tumor like medulloblastoma, it just goes, invades, and breaks the entire barrier. So in that case, the contrast enhancement would be uniform. And if it is a little high-grade glioma, where it is not equally going, it's heterogeneous. So in that sense, I will get a mixed enhancement on a contrast. If it is necrotic, I'll get a small rim. I have image, I'll show that to you. There's no effacement when there is a low-grade tumor which is not invading the blood-brain barrier. So this is regarding the contrast. So as I told you, the flare is a flip side of T2. So what I analyze when I, get to see a image. So there is a necrotic mass, and around that, there's an actively dying center around it. Okay. And flare gives me a more insight into that. Okay. And these are the the ones in more in the perimeter, which are about to get into the edema and are going to get the ischemic insult. Also, so you have something called a sequential weighted imaging. So this will let me know what is the calcification, what are the tumors which have the calcifications. Then I would like to see in this sequence, and then hemorrhages or any susceptible defects are seen with SWI. DWI will go in detail. So craniopharyngioma is one tumor which has very massively, it gets a calcifications. And next comes the oligodendroma or ependymoma. But ependymoma has very fine stipulations, and medulloblastoma is totally rare. And coming to the hemorrhagic, ATRT, atypical teratoid rhabdoid tumor, we will get into the details also. It frequently, it gets hemorrhage. I saw the image first in the pediatric oncology textbook. I thought I saw a heart. There are 4 chambers, is what I felt. It gets into hemorrhage so frequently. You try to put the child on the protocol, you start giving the chemo, there will be a new neurological deficit, and then I image again, then the child's sensorium is gone down, there is a new hemorrhage. It's so notorious to cause this hemorrhage. And then, yeah, the high-grade gliomas, they have most common with the grade 4. There will be an hemorrhage. Pilocytic has less frequency to tendency to cause this hemorrhage. So MR spectroscopy, one we need the most in high-grade malignancies, where you have few chemical parameters which will let you know what is the disease type. Okay, so a choline, which gives you the cell turnover, money, the membrane metabolism. Of course, they're rapidly dividing. Things like medulloblastima, it is elevated in this. And NAA is a neuronal marker. It's like an axonal, your axonal integrity is given by NAA. And lactates will, of course, cause an anaerobic metabolism. It increases in anaerobic metabolism, like your, post seizure and all. And so, if you have a high choline with Na, the tumors, they are usually in high grade or aggressive tumors. The elevated lactate, as we thought, it's in hypoxia, which serves a poor prognosis. And the lipids are peak, it is in usually cystic diseases or in necrosis. So just remember, Na is a good one, choline is bad, and lipid is an ugly one. So as I told you, contrast is for vascularity and spectroscopy is for chemical environment. You're knowing this. Now we'll dive into these two, the perfusion and diffusion. So DWA, what does it mean? Think there's an intra and extracellular environment. There's osmosis going on. There is water being diffused all over, right? When there is a new person, there's a new cells which are growing very rapidly. The tumors, in the sense, one which are highly cellular, they are not allowing any of the water diffusion to happen, and that is causing a restricted diffusion. Okay, the ADC. This is a parameter which quantifies the diffusion. Okay, and so that ADC is restricted if the cellularity is high, meaning the ones which have very high cellular load turnover or highly malignant tumor. And if there's low cellularity or necrosis, there will be an unrestricted diffusion. Okay, I'll just remember two or three things for the ADC values for your long-term remembrance. The pilocytic astrocytoma, you see, it's 1.65 versus ependymoma 1.23 versus medulloblastoma 0.66. At least remember one, medulloblastoma has a least ADC. The value is 0.6, much lower. Why? The disease is very malignant. It is not allowing the diffusion to happen. It has much restricted diffusion. Okay. So, where I'm applying in tumor grading, of course, as I told you, a high ADC suggests there is a low grade tumor, and it is differentiating. It helps me in differentiating MB versus pilocytic astrocytoma, and it also helps me with I know where is the diffusion, how is the diffusion, and then I can choose where is the possible site of biopsy. Me, the neurosurgeon, will sit together and then plan where I can get the good chunk for the histopathology or for the molecular characterizations. And I will also be using this to detect any residual or recurrent diseases. And then the perfusion imaging. So the blood flow is being so much of dynamic in sense, which is happening with the brain. So this dynamic susceptibility, with the help of contrast, they gauge it, they measure it in the form of a regional, that particular the tumor site, it will be measured. That is called as a regional cerebral blood flow. If that is high, obviously there's a high vascularity, the cells are dividing rapidly there, it's a high grade tumor. Simple, as simple as that. So it helps to grade my tumor and also assess the prognosis. And it also differentiates me to know what, if it is a tumor progression versus radiation necrosis. Multiple times, the child will come, they will be under survivorship program. They'll be coming to us every 3 monthly or, 1 monthly based on the tumor, which is, I need to know if it is a radiation necrosis or a progression, if the child has just come in a altered sensorium, if it is causing something. So then this perfusion will help me. If there's necrosis, there's no perfusion in there. And it also gives me an idea if my treatment is working well or not. So This is the region. Sorry. So this is the regional cerebral blood flow which is happening, and this is how we see that. So we will distinguish if there's progression or if there's a treatment effect that's happening. So there's something called a functional MRI, which is seeing the cortex, what is the motor, language, and the visual areas, how are they affected, okay? And I will see, even while happening surgery, it will make me, the surgeon, he will be aware about the neurovascular functioning, where is he dissecting into, so that the post-op neurological complications are minimized. So this is tractography, where is it? You see this. This is a 3D image where it is showing the tracks. The visualization of the neural pathways is helpful with is seen with this, and so that they will minimize the post-op neurological effects. And while doing the surgical planning, they will, examine the critical areas if it is not involved. You saw this. This is just making a got viral. So this is Mr. Goyal, the CEO of Zomato, Dipendra Goyal. So he's wearing this new gadget on his temple. It is something similar to our near infrared spectroscopy, where while the surgery happening, CABG, things like that, where they put a sticker here and they'll see here, the electrodes would know what is the blood flow. Something like our NIRS. This is to see the effect of gravity over age, and is gravity affecting our aging. This is what he wants to see, and the device name is Temple. So it's been ages and decades we are going through all this imagings, and this guy has now come up with this gadget. Let's see what it will take us to. So I know this background basics. So what am I seeing in the tumor? Where is it originating from? The size, shape. What's the intensity on different imagings? What are the number of the lesions? Which lobe is this distributed into? If it is supratentorial or infratentorial, is it causing an edema? Is there a effacement of the meninges, is there is a local spread? All this I am getting an idea, along with the midline shift and mass effect. And what more do I see? Gray white relationship is what I need to see about. I mean, mostly with the surgeons also. And if there is a ventricular block, and what are the margins like? Is it solid, cystic? And what's the calcification? Is there a bleed? What is an MRS image on the in the particular image? What is the DWI in that? All this I have to see while I am seeing a brain tumor. So let's enter the maze. We will start with the intratentorial or the posterior fossa tumors, and then we will see the supratentorial ones. So we will go in the same order: cerebellum first, and then the fourth ventricle, brainstem, and the foramen of Lush-Cornegenti. Initially, we'll start with the symptoms, as Dr. Jayanth was pointing it out. Early morning headache. Why? The CSF tends to get accumulated by the time the child gets up. He wakes up with a morning headache, and it's also postural for him. If it is less than 3-year-old, usually they tell out. I mean, their symptoms speak out in the form of irritability, lethargy, or poof feeding. Vomiting. If hydrocephalus is there, yes, it is definitely early morning and it relieves with headache. But if it's a fourth ventricle tumor where the vomiting center and the vagal nuclear irritation is happening, it can happen at any time, relentlessly. There's no relation with the headache. And macrocephaly, yes, because there's small child, there is sutural diastasis, the AF is wide, and usual the star sign is that sun setting or sundowning gaze preference is where you see, and you have a lower limb hypotonia initially, and then slowly the child will get into the spasticity. Yes, there will be developmental regression, motor cognitive behavior. As sir was telling, see, it would be acute versus subacute and then chronic based on the how fast is the tumor growth. So with regard to ataxia, yes, if it's a midline tumor, then the child would come with a wide base gait, fall to the either side, and there is a tandem walk. But if there is limb ataxia, then I would think of, there is only fall to one side. Then I would think the lesion is in the hemisphere. There are rapid alternating movements happening in there. And then ataxia, truncal, even when there is hemispheric, it can happen, but that's because of the hydrocephalus. So very early pickup in the form of where we can see, that hopping and circle type of walking where the child presents with. And tone, yes, you are aware. If there's hydrocephalus, yes, hypotonia, hyporeflexia, but this is only initial. And as the spasticity, hyperreflexia coming to picture, then I would think of the brainstem compression. But if it is a truncal ataxia, early spasticity, or if the reflexes are very brisk, and then yes, it's a brainstem. The cranial nerve deficits, of course, the pseudo-localizing sign due to raised ICD from the posterior fossa tumors. So if it is unilateral, yes, the lesion I would think is in the pons. If it is in midbrain, it's usually 3 and 4. If it is medulla, then, the pooling in the secretions where the mother, comes saying that child is not able to feed, there's a weak gag, not able to cough out. This deviation of tongue, uvula, and dysphagia, dysphonia, and dysarthria. Yes, you see this. This is an upgaze palsy, the sun setting sign. And then with pons, you have a horizontal gaze palsy. So the type of nystagmus, as we see, it depends on, all these are the T1 weighted images. If there is a cerebellar hemispheric lesion, that would cause a horizontal nystagmus. It's a brainstem one. I typically remember, of course, with the reasoning, but I typically also remember with the first letter. The brainstem lesion, it's a vertical. The horizontal is cerebellar hemispheric, and if it is torsional, something like torsional is medullary. Upbeat nystagmus, we've just seen there is, if the lesion is in the vermis, and if it is in a cervico-medullary junction, then it's a downbeat nystagmus at presentation. So posterior fossa tumors will start with initially the theory part and then also add on the images. The most common one usually happens with 5 to 6 years. It can be cerebellar mostly and also hemispheric. So it presents very rapidly, like in less than 3 months of, it progresses. And if the lesion is midline, you have this truncal or gait ataxia. There is stiff neck if there is a tonsillar involvement. A back pain usually, it comes when there is a seedling, there are meningeal signs, and then also presents with the seizures when there is a subarachnoid involvement. As I told, it's a high grade. WHO has classified it into a grade 4 tumor. So these are the types. Just remember, WNT is good prognosis. 3 and 4 are poor prognosis. 3 and 4 are in the center. WNT is up and out. And another variant, which is little slow growing, it goes over several months, pilocytic gastroma, which is a close DD for medulloblastoma on an image. So it's an hemispheric lesion, so that's why it will be an appendicular ataxia with a little of clumsiness with the limbs. And yes, without cellular signs, you might have vomiting, microcephaly, coma, or altered behavior. And next, ependymoma is the second most common tumor of the posterior fossa. Peaks in ages 2 to 8. The duration of presentation is intermediate, 3 to 4 months. It usually progresses. If it is, just because it's, close to the area postrema, the recurrent vomiting would be one of the signs. And torticollis, will happen. Pontine glioma is it also progresses very fast. As you know, the pons is immediate red flag for you. So within a duration of 1 to 2 months, there will be progression. There will be seen as deficits in the form of, all the long track involvement causing ataxia and of course hydrocephalus. It just, cuts off the CSF flow in there. Rest all are the Pons lesions. So next is the cerebellar hemispheres. So we'll see. So if it is anterior part of cerebellum, it's usually LGG is low-grade glioma, MB is medulloblastoma, PA is pilocytic astrocytoma. Just for, short forms, I'm just detailing you further. And the posterior cerebellum, usually it is PA, the periphery, just remember as PA, posterior, or occasionally medulloblastoma can also be there. So how is the medulloblastoma? Yes. So how does a medulloblastoma seem to you? So on a T2 image, it sees as a solid mass. There is an iso-intense lesion on the T2 and also a flare images. Okay. As I told you, the cells are tightly packed. They are of high cellular. So the ADC is 0.6, which is the lowest of what we have seen. So post contrast, there is a strong homogeneous enhancement. You see, there is strong homogeneous enhancement. So the ADC pattern is what? This is where it helps us to differentiate because the prognosis differs, the treatment differs with the pilocytic astrocytoma. So that's the reason why ADC is very important here. So as I told you, see the ADC here? It's very dark. Okay, this is MB, medulloblastoma. And this is pilocytic astroma. You see the ADC here? It is 1.6, right? It's the same before, the two contrast images. You see this? See how beautifully is the perfusion is intact, maintained with the pilocytic astrocytoma. See, there's a cystic space, there's a solid space, which would allow the perfusion to happen, and that's why the perfusion is so intact, unlike in an MB. So as I told you, just remember, see the anatomical locations. Just remember, group 3 and 4 are dangerous and they are readily causing a hydrocephalus. And next, the fourth ventricle. So usually, yes, the fourth ventricle tumor, initially I would think of an MB and less commonly it is than EP. So in MBs, usually the medulloblastoma, group 3 and group 4, which I said are of poor prognosis. Group 3, see here, it's just ready to cause the hydrocephalus. It's already getting in there. The same here, see, I don't see any. It's just obstructed in the entire contrast image. Ependymoma are of two types. One is on the lateral side, one is in the mid-floor type. Okay. So if the ependymoma is within the fourth ventricle, see this one on a T1 imaging. So it would be on, you see this on the flare, there is a mixed signal. Okay. Okay, it gets into the, the extensions are very fast and it gets extending into the Lashka foramen of Lashka. And as I told you, they are fine, small little calcifications if you could appreciate. And post contrast, there will be a moderate effacement to strong. So there's another type, lateral recess type. It's just the location. So how do I differentiate between medulloblastoma and ependymoma? Yes, again, it's DWI. We have seen the values prior. So here it's a moderately elevated DWI signal. As I told you, calcification is the key to identify an ependymoma. See this versus in DWI. Sorry. So this is an medulloblastoma and this is an ependymoma. On DWI, yes, this one's. It's the same image. WNT is just the better doing type of medulloblastoma. And then to the foramen of Lashkar, the CP angle tumors, we have most commonly to differentiate to ATRT is very, very malignant, very aggressive. The child would progress down the neurological, the sensorium drops very rapidly if it is ATRT, unlike an ependymoma. See the ADC of both. See, and this is so bright. This is of ATRT. There's a lot of bleed, there's a lot of hemorrhage being happening into. And then the brainstem lesions, yes, if it is pons, always remember pons, it is a high grade glioma, which is very, very common. And next comes the low grade glioma or ganglioma. And if it is brainstem, yes, it is a low grade glioma, which is most common. So these are the pontine lesions on T1 images. You see, this was a case of high-grade glioma, if I remember. Yes, it was a high-grade glioma, which is just pushing all the structures away. This was, see the image. There's another, see, there is the T1 image, which is heterogeneous here after contrast. Extrapontine lesions I have technically not seen yet. This was not my image. This was from one of my friends. And yes, not really aggressive like the ones which are pontine. And then pilocytic astrocytoma, it's a low-grade glioma. I'm happy if the child gets this, the child will be on week 80 of, chemo protocol, getting a CT and RT. They will be long living. Of course, because of the biology, tumor biology, it is graded as WHO grade 1 and has an excellent prognosis. Cerebellar hemisphere is the most common typical location, but it can also occur on the supratentorial regions. And usual ages of presentation will be 5 to 14. This, we will see the image and I'll keep you, yes, see this. So there's a huge mass. Along with that, it has a cystic component which is filled with the fluid, and there is a solid component. This is how pilocytic astroma is differentiated with an MB. So this mural nodule is where which gets the contrast enhancement is which will clinch you the diagnosis. It will be heterogeneous. At times the cystic mass will be more, at times the solid component is more, but it is that heterogeneous thing where you see on T2 flare a hyperintense image. So that is pilocytic astrocytoma. And brainstem tumors, as I told you, if it is in pons, mostly it will be high grade. Low grade astromas are also common, but then if you see something which is progressing very rapidly, you don't even need an image. It is you don't need any histological evidence to say it, and it is evidence that it's a high grade glioma. Yes, the surgery will be a challenge. And this, I don't have an image. This was from the textbook of Pediatric Oncology, PISO, where this is a diffusely, see this, infiltrating the entire brainstem. The T2 image, where there is actually, see this, basilar artery is completely engulfed. It's so invasive, right? It takes up more than the 50% of the transverse diameter. Of course, the prognosis is poor. Right, so if there is recurrent unexplained vomiting, I'm concluding the posterior fossa tumors, so we think of PFT. And then if they are infants or pre-verbal children, always if they're irritable, poorly feeding, with think that it is an indirect sign of their headache. And gait ataxia, it has to be ill-sted because most of the times it gets unmasked. And then little salient features, if it is pilocytic astroma, as I told you, it's cystic along with a solid component, remember that. And also the ADC of 1.6. MB and ATRT are intensely diffuse restricted images, okay? Excuse me. And then ependymoma, as I told you, it creeps. There is an intermediate restriction. It's in between pilocytic and MB. Pons, usually HGG. If Pons is paired, then think of a low-grade glioma, LGG. Okay, so pattern of enhancement, the hemorrhage and calcification are non-discriminant. This is one disclaimer. So this is a summary for posterior fossa tumors. Now, coming into the supratentorial anatomy. So this is probably most of you what you see in most of the regular practice, where you can just pick up if there is a hemispheric lesion. But then if it is an MB or PA without getting any of the molecular diagnosis or the histopathology, you will be able to further tell, hopefully based on this presentation, if it is an MB versus pilocytic astrocytoma. Midline structures, yes. Pineal, pituitary, and third ventricle, they can be involved. There will be lateral ventricular or gyre and sulci effacement that we will see in few of the tumors, and very rarely we get to see GCT and craniopharyngiomas. I've seen only one case though. So the low grade ones, as I told you, pilocytic astroma is like it's a group, the first in the group, which is more common than the oligodendrogliomas. They're often cortical and they're just paraventrical. So they are low cellular, so that's why the ADC is high, and there is a variable enhancement as we discussed. High grade gliomas, on the other hand, usually the diffuse astrocytomas, as we spoke, it's of grade 3 or 4. They are highly cellular. You see this rim pattern here. This here. So this heterogeneous pattern is very much characteristic of high-grade gliomas. Okay. And of course, there's necrosis and hemorrhage because of the rapid division of the cells there. Craniopharyngioma, honestly, I have only heard of and not seen in the past 3 years, though. I have seen one much prior. Yes, it does come. It's a non-glial tumor, of course, cellular or supracellular location, but I feel that it's definitely a locally aggressive tumor. Even the histology is benign, even it's not invading into the surrounding structures, but locally it is very aggressive. So on the sagittal image, see the cellular mass. So it could be cystic or solid mass. The coarse calcification, as I have already discussed, it's a coarse calcification which is very pathognomonic of the craniopharyngioma, because I mean there is also in the cyst, as apparently there's a rich protein content because of all the secretions, so that's why it is hyperintense cyst. It also has a mural nodule, but don't get confused with pilocytic astrocytoma because this is more in the cellular. And hydrocephalus and pituitary axis displacement, yes, definitely expected. And then germ cell tumors, seen as germ cell tumors, if it is there, mostly it will be a germinoma. Okay. And usual age is 10 to 25 years. They are radiosensitive and they'll just melt with chemo. So never miss them on the diagnosis. So this was not my image. This was given by my friend. And they see this one. The midline location, the pineal, and it is supracellular. They're strongly homogeneous, and the calcifications are not seen compared to teratoma. Teratomas are usually very much, they're just picked up by their heterogeneous presence, and there is the calcified component also in there, which doesn't happen with this most common germinomas. Hydrocephalus is usually due to the aqueduct of sylvius compression. Pinealoblastoma is one of the most malignant, most aggressive embryonal tumor. It has a highly metastatic potential. The thing is, it also has a solid appearance and high ADC. But the thing is, it has an heterogeneous enhancement. This enhancement is heterogeneous on a contrast enhanced image. And yes, of course, because it's right beside, there will be seedlings, there will be a CSF and spinal cord metastasis, very rapid than many of the tumors we have seen. And then the last one, the atypical teratoid rhabdoid tumor. Why is it so? The rhabdoid tumors are inherently they're thought to believe to come from a mesenchyma of kidney. Okay, but there is also few structures in the brain, few the mesenchyma in the brain, which had got into this histology, which is atypical teratoid. Okay, it's because of this gene loss, it is biallelic SMARC B1 is what we see for. We had a child whom we got this tested and she was positive for. Of course, she does not survive. And these are they can occur anywhere. The one which we had, she had most of the supratentorial, never in the posterior fossa, but still she had very rapid progression. And as I told you, she had multiple hemorrhages, multiple episodes of hemorrhages. So as I told you, see, the initial image when I saw first, I mean, it was just looking like a four-chambered heart. This was all the hemorrhagic part, which is giving its very heterogeneous and variable effacement pattern. So what all we've just almost come to the end of the topic. The imaging you usually need for the surgical planning is the most, of course, I agree. So very, very important is a child. If LGGs, they survive forever. So make sure we need to be very much in tumor board. We just, sit and sit for hours to see what is the functional impairment with the child is going to survive with. Okay, so in that sense, the functional MRI is very much important for us while we discuss in the MDT. And of course, in relation with the critical structures. And for the radiation oncologists, as I told you, they need to know what is the gross tumor volume so that they can go target that. And that is usually best seen on this multi-sequence MRI. So there's something called clinical and also a planting targeting volume. They will see a microscopic disease, which is in the periphery. And PTV is just for, it's not like, your muscle or some other part of the body, abdomen, where you are accountable for setting up an error. Okay, that planning targeted volume, this error should be minimum in brain tumors, especially with the children. So PTV is very, very important for the radiation oncologist who is planning for the radiation. The whole neural axis, you get to see the MRI with the CSF staging for all the high grade tumors, because the tumor seedling you can see better. Radiation necrosis, as I told you, this has a low perfusion, right? The cerebral blood volume is very, very much less than a recurrent tumor when you see a progression. So for assessing the chemo response, what would I do? How would I see? What is the baseline and what is the next one? So how do I identify? So we have few scores. I'll come to that later. The CSF metastasis, which could be detected on the entire spinal examination along with the CSF fluid examination. So post contrast, if there is an enhancement in subarachnoid space, yes, that is a red flag for me. That shows that there will be a meningeal signs along with the CSF involvement. Early detection, of course, will impact my treatment. I would think of probably adding in intrathecal regimens along with them. Many of the children will be on Omeya reservoir, where we will give instill the into the Omeya, the methotrexate values, which we will be sending, for the methotrexate levels. So as I told you, how do we gauge the response? Okay, so we will see something called as response assessment, in neuro-oncology. Okay, if there is a complete response, there is no enhancing disease. If there's more than 50%, I would take it as a partial response. Stable disease, yes, there's no change. The entire disease is almost stable. But to say it as a progressive, it should be definitely more than 25% increase in the tumor volume. So when do I call the child for surveillance? Of course, the parents will be anxious. They will be worried about what the tumor is going to cause if it is recurring, versus what the radiation, post-surgery, post-chemo, what are the side effects. So for that, we have a definite survivorship program, which gives us when to follow them up and when to scan them up. So for all high-grade tumors, we do post-treatment baseline, we do at 4 to 6 weeks, and then 3 monthly, and then 6 monthly, and then yearly. This is over next 5 years. For low grade tumors, I would not go this hard. It will be only 6 to 12 months. And if I am seeing any recurrence, then it is usually 65% before the symptoms, the imaging would pick up. So, not just the symptoms, probably the disease biology should also hint you when to image earlier than this schedule. So, the late effects, as I told you, the chemo. We have a child who had leukoencephalopathy. She completed her entire lymphoma protocol. She was on orcopadam and all. So because of the methotrexate, she landed up with leukoencephalopathy. It was just white, right? There would be cerebral atrophy after the post-radiation or post-surgery. There will be a volume loss. Yes, second malignancies are possible. It's actually said that in 1940s, because of the tinea capitis, they used radiation that had caused secondary malignancies. This was in 1940s. And now, just because we have advanced treatments, there's SRS, there's SBRT, where you have nice radiation techniques, you are just using only in a particular localized site. But this can cause a certain malignancies. That's one thing which always, kills me in mind while I am seeing the surveillance scans. Yes, of course, the vascular changes. There will be usually a raised ICT because of the vasculopathy post radiation. This all will require a long term DEXA. So, what is this exactly making? What is this motto of this presentation is? I am standardizing the protocol because of of this baseline common guideline. If we start to follow and detect the cases early, we can catch the disease early, start a treatment, and that will give us a harmony in clinical trials in all the new treatment protocols we are designing. And also, this will minimize the anesthesia time in younger children. For every scan, for every radiation fraction they're going every day, for every chemo port incision, every time they have to undergo anesthesia. But if I have a standard protocol, everything I can minimize. Every episode of anesthesia I can decrease. And reproducible imaging for a longitudinal comparison over time. All this is possible if we follow the protocols. So, key takeaways in general, MRI is the cornerstone of pediatric neuro-oncology. So, integrate the location, morphology, the imaging, and molecular classification. I didn't go into the depth of molecular classification, but hopefully you all remember what all we spoke about. That should get you to the accurate diagnosis and treatment guidance. Even for the matter, there is no HPE. With this, strong points, landmark signs, you should be able to get through the diagnosis or at least guess. This is how our assistant and associates used to interview us, and they used to post the video and they'll be like, tell, what is it? Like that. So, this is a key takeaway in general and in specific, as we spoke about. I am repeating again on the posterior fossa tumors only. So if it is an irritable child who is having poor feeding and who's not able to tell headache, think of PFT tumors. And if it is an unexplained vomiting, think of PFT. And yes, the low ones, I think I've emphasized enough. Probably these last slide should be your take home message kind of slide, even if you have slept through the initial ones on a late Monday evening. So, sincere thank to my mentors and patients. This Dr. Shanta, who has devised the MCP protocol for leukemia children, first in India, because they were dying because of they were malnourished. They could not take the strong chemo. She, along with Anne McGrath, has designed a protocol which has given good results, and she started the first pediatric cancer unit in India in Chennai Cancer Institute. So this is our medulloblastoma child. If Katija, you see the Temoya reservoir. That's how we used to like religiously manage it. She never got into any of the infections. We were like, our professors were really proud of us. And this is Hasini, who has, I think she's optic glioma. Yeah, this was a spot. So, because it's a girl child, the father neglected and did not come on time when there was a pus over the chemo port, and child had a open chemo port seen there. And these are LGG child. All these three are still alive. These are like 3 years back. They're still alive. This is just to, give you hope that not all brain tumors kids die. They're alive till the last time. I started doing the PPT. I tried following up these kids. They are still very much alive. And this is my department, Dr. Venkatraman Radhakrishnan, our HOD, Pediatric Onco, Dr. Gargi and Dr. Prashant and Dr. Balaji, the team of 4 doctors of Pediatric Onco Adihar Cancer Institute. Um, this is an amazing art by Tota Tarni, the artist in the Pediatric Oncology block. That's it.